Good evening, everybody. Welcome to our joint meeting with Greek IBD Society. Welcome, Professor Nikos Viasis. He is the president of Greek Hellenic IBD Society. And welcome, Eva Zampeli. She is vice president of Hellenic IBD Society. We will moderate this meeting with our past president of Turkish IBD Society, Professor Aykut Ferhat Çelik. Our colleagues will talk about real-world data about JAKs with two cases. Please, Professor Aykut Ferhat Çelik, maybe you want to say something.
Yeah, thank you very much, Feliz. We are very happy with Nikos here with us, with Eva. So that Hellenic Society of Gastroenterology, we had a few meetings together. Then this is keep going. This is very, very successful. Is going to be, I believe. So then this is nearly the first Zoom meeting between us, two IBD Society. So today, Nikos and Eva are going to talk about the real-world data behind the JAKs. So everything about the JAKs, the phase studies, also the real-world data, then they will also supply two cases, then we will discuss on. Thank you very much, the Nikos and Eva. Then now this is the talk is yours now. Thank you very much. You are being here.
Thank you very much. The pleasure is ours. It is a great pleasure and a great honor to organize this joint meeting. I am Nikos Viasis. Yes, I'm the president of the Hellenic Society for the Study of IBD. And it's really very important, this collaboration we have started with Feliz and the Turkish IBD Society a couple of years ago. We have welcomed you in Greece. You have invited us in Istanbul, and our friendship and collaboration has started a couple of years ago and is continuing. And I'm really would like to tell you that it will continue in the future as well. In a couple of months, the president, Eva Zampeli, who is now the vice president of our society, is going to be our next president. And she will continue this collaboration with Feliz. Of course, all of our members, we have started, we have already published data about the infliximab, about the anti-TNFs. We are starting a new collaboration with a new project, and our two societies will continue to work together for the benefit of our patients and of our colleagues. So this is a new initiative. It was Feliz' idea. Feliz, we would like to thank you, both me and Eva, for this idea you had. It is a great honor, again, I'm saying, to be here together with you. So I will pass the project to Eva. We'll start the presentation. In the meantime, I will present in the meanwhile also some cases, and we can all discuss about the JAKs today. Thank you very much.
Now, good evening, everyone. Thank you very much for the kind invitation. I'm very honored and pleased to be here with you. Now, here are the conflicts of interest, and this is the structure of this presentation. Let me say in advance that we, myself and Nikos, have prepared a presentation including not all the data regarding JAK inhibitors. We have focused on upadacitinib, which I think is the one that's mostly prescribed in Greece, but I will show you a few data about tofacitinib as well. So Nikos will intervene on two occasions when he will present the cases of a patient with Crohn's disease and the patient with ulcerative colitis who have both been exposed to JAK inhibitors with different outcomes, as you will see. Now, let me start with the fact that we're talking about a brand new mechanism of action. And perhaps you've heard, you've read that JAKs are the interior part of these transmembrane proteins that receive the inflammatory signal from various cytokines and then transmit this signal to the nucleus, where transcription of other proteins involved in inflammation begins. What these medications, these small molecules do is that they inhibit this signal transduction. And in this way, they block this vicious inflammatory cycle. This is what they are intended to do. Now, the first generation of this medication includes tofacitinib, which is a pan-JAK inhibitor. It acts on all receptors of JAKs 1 to 3, whereas the second generation includes filgotinib and upadacitinib that mainly act on JAK1, but perhaps they may have a mild effect on the other two as well. Let me start with the clinical program of upadacitinib in Crohn's disease. These were two similarly designed phase 3 studies that included upadacitinib at a dose of 45 milligrams. That's the maximum dose of the medication for a period of 12 weeks. This was the induction period. The medication was offered for 12 weeks, and then the responders, this study was based on responders' re-randomization pattern. And at the end of the induction period, the patients, the responders, could then enter the maintenance phase of the study up to week 52, and they could receive either placebo or the two lower doses of upadacitinib, either 15 milligrams or 30 milligrams up to week 52. Now, you can see here that the primary endpoint of this registration study was met, and this endpoint contained both clinical remission and endoscopic response. And significantly more patients that were offered upadacitinib managed to be in remission and responded endoscopically in compared to the patients who were on the placebo arm of the study. Another very important finding was the fact that many of the patients that initiated the study whilst taking steroids, and these were sicker patients, let's say, these patients in the vast majority managed to achieve clinical remission without steroids. So these are very powerful medications that help patients wean off steroids. And another very interesting finding is the next one. You can see here that this post-hoc analysis of the clinical program showed that in terms of all outcomes that you can see here, the medication upadacitinib was effective both in the naive population on the left, on your left-hand side, and the exposed population of patients, where, as you can see, the deltas were very high. We have a long time since we've seen such high numbers of delta. The difference of the results from placebo were very high. So this is a medication with a powerful effect, of course, in naive patients, but also in patients who are more difficult to treat, let's say, the patients who have failed other treatments. Now, let's see what the real-world practice shows about upadacitinib in Crohn's disease. This is the Spanish registry that involved 300 very refractory patients, and you can see that 1/3 of those patients had failed at least 4 advanced treatments in the past, and the results were really striking, I would say. 2/3 of these patients achieved clinical remission at week 52. And you can see the results as shown in the diagrams, where you can see the significant drop of fecal calprotectin, Harvey-Bradshaw index, and CRP from baseline to week 52. So very, very solid results. This is a cohort from the USA, again involving 300 and more patients. And what they looked at was clinical remission and endoscopic response in the case of this real-world study at week 24. This means something like 6 months from the initiation of the study. What they have shown is that the result of this intervention with upadacitinib was very successful. And let me point out this percentage of 97.7%, which refers to the response to the clinical remission that was achieved for naive patients who were treated with upadacitinib. And let me just say something that we already know from clinical practice, that any treatment that we have decided to offer to our patients, its effect is better when it is provided early on, any treatment we're talking about. And that's the case with striking results with upadacitinib as well. However, the medication is also has a powerful effect in the exposed population as well. Now, this is the cohort from the UK with 100 patients. Again, very difficult to treat patients. 40% of those had failed at least 3 advanced treatments in the past. And again, the response was very, very good. 62.8% of these patients kept on taking the medication. This is what we call persistence. And you know that when we're talking about persistence, we mean that the medication is both effective and safe. It was very well tolerated by the patient, so this was a very satisfactory persistence for the medication. Again, shorter disease duration. In other words, the earlier the intervention with upadacitinib, the higher the persistence that was seen with this class of medications as well. Now, let me say a few words about our experience, our initial experience in Greece. Back in 2022, when the medication was not yet available in the market, we had the opportunity of importing the medication from abroad through an early access program. So 24 Crohn's patients, very refractory patients from different tertiary centers all over Greece, were offered this medication through this early access program. These patients had a mean disease duration of 11.5 years. 45% of those had an ileocolonic phenotype, and in 70% the phenotype was inflammatory. Now, let me point out one more interesting thing. The fact that 60% of these patients had extra-intestinal manifestations. And that's really very important because this class of medications has a very broad range of indications. So they are a very, very attractive candidates for patients who have, apart from intestinal inflammation elsewhere in their body. Now, as you can see, 36% of these patients, these 24 patients from Greece, failed 4 advanced treatments in the past. And you can see here the range of therapies that these patients have been exposed to and failed. And you can see that, for instance, two of them have even been included in clinical trials, having received guselkumab and ozanimod. They were not available at the time. It was in the context of clinical trials. So we had nothing to do with these patients. And look at the results. The results during the induction period were really remarkable. You can see that Harvey-Bradshaw index, calprotectin, and CRP significantly fell up to week 12 from baseline. So this was a great response, I would say, for these refractory patients. And this very good effect came without serious side effects. You can see here the 3 problems that were reported, and I will come back to safety later on if you like. Now, let me stop and pass the floor to Nikos in order to present the first case.
Okay, thank you, Eva. The question, do we have any questions from the chat that you would like to address right now, or we can go on with the case about Crohn's disease?
We can go with cases, I think.
Okay. So I have, this case is a real case scenario. It's a patient that was treated here in Evangelismos Hospital. So we are talking about the 41-year-old male. He's working in a maritime company and he's traveling a lot. This is important for the decision we're going to have to take in a little moment. So he was traveling abroad quite often. Several months he had abdominal pain, anemia. As you can see, he had slightly elevated white blood cells. He had slightly elevated platelets and ECR elevated. CRP was also very elevated, 7. Our normal, upper normal limit is 0.5. And calprotectin was also high, 1,500. So it's absolutely clear that this patient has markers of inflammation. He has abdominal pain, anemia, no diarrhea. He didn't report any diarrhea, but he was, everybody was sick. We thought that he had Crohn's disease, and he was, let's go to the next slide. Yeah. He had a colonoscopy, and as you can see in the image, he had the stenosis in the orophyseal valve. The large bowel mucosa was normal, but the endoscope could not be advanced further down into the terminal ileum. The biopsy confirms CD, so he has Crohn's disease. And according to the molecular classification, of course, it's an A2L1B2 disease. So the patient we have a newly diagnosed patient with Crohn's disease with the stenosis in the terminal ileum. He continued with the MR enterography. I'm sure by now that you would do the same. So he has terminal ileal thickening. The length is approximately 15 centimeters, thickness 9 millimeters, pathological diffusion restriction, whole neural enhancement after IV administration of paramagnetic substance, and significant ileocecal valve stenosis. So we have, as we already told, a terminal ileum disease, stenotic disease of the terminal ileum with normal bowel, large bowel. So the question now comes, medical treatment or surgery? I don't know who would decide on what, who would go take this patient to surgery. Of course, it's a newly diagnosed patient. Both options are probably available, and both options have their pros and cons. And I don't think that the bibliography or the data are conclusive about the one or the other. The patient has not received any treatment before, so we don't know if the stenosis is fibrotic or inflammatory. Probably in most cases, both components are there, both inflammatory and stenotic. Usually when we have a young patient, he was 41 and he was now diagnosed with Crohn's disease just a couple of weeks ago. Usually patients don't want to go to surgery. And I think that also, in my personal opinion, I think we would like to try medical treatment before taking the patient to surgery, since he didn't have also an episode of ileum, or he didn't have any, he had pain, but he didn't have any obstruction evidence. So, and he had also, this is also important, I think, he had also elevated inflammatory markers. So this was important in my mind to decide what should we do. And we decided to go on with medical therapy. He received ferrum IV because he had anemia. He was anemic, and he was started on upadacitinib 45 milligrams once a day per host. 5 days later, he had no abdominal pain and improvement in CRP. This is really important and it's impressive. I don't know if you have tried these drugs. I think they are available in Turkey, right? No?
Yeah,
Yes.
Yes. Can I ask something?
Yeah, of course, of course.
In Turkey, generally, we can start after one biologic treatment.
Okay.
And
Okay.
not as a first-line treatment.
Yes,
And
yes.
can you use in Greece as a first-line therapy?
Yes, yes, we can start. We can use it as a first-line therapy. It's we are allowed to do so, and we have no constraints. I know that in many other countries, it's important that the patient has failed 1 or 2 biologics before they can prescribe drugs. Also, I think in the USA it's the same thing.
Yes, we
But
can use as a second line.
Yes,
In fact, sorry.
Sorry, here in Greece we don't have any restrictions, so we can start the patients as a first-line therapy.
Maybe it's useful for this case because we know that even anti-TNF therapy, ileal involvement patients, drug sustainability is low. So
True.
maybe upadacitinib is good for this patient as a first line.
The decision, of course, we could start anything. We could start, anti-TNF would be the most, let's say, the first thing that comes to our minds. Anti-TNF is the first treatment that we would give to this patient. We have a lot of experience with using anti-TNF in such patients. And we could use anything. We could also use ustekinumab. We could use also maybe vedolizumab. I don't know. Probably anti-TNF and ustekinumab would be a good choice. But the patient was, as I said before, was traveling a lot, and he wanted to take something like a pill would be more suitable for him because he could carry it with him in the aeroplanes and in the boats. He was a mechanical engineer, and he was the company he was working was sending him abroad to places like Morocco or like Algeria or like Asia. So he was very worried that he could take all the medication, the injections with him. And so I thought that upadacitinib was really a good choice for him. And indeed, the drug worked. And that's what I wanted to say, that it's true that when you start upadacitinib, if it works, you see the results after 3 days. After 3 or 5 days, you can see improvement. It's really one of these kind of drugs that something we haven't seen before. That they start if they act really, they act fast, and this is important for our patient. So 5 days later, there was no abdominal pain and improvement in CRP. So I think that upadacitinib helped him treat the inflammatory component of the stricture. I usually tell the patients that there is no magic bullet, there is no magic drug that make the stenosis go away. Usually in Crohn's disease, when the stenosis is there, eventually at some point the patient will go to surgery. But as long as we can delay it, I think that it's a good thing for both the patient and for us doctors. So I think, I don't know if you, I think that you agree, Phyllis, also Professor Celik, that medical therapy is an option here in this case and not surgery right away.
Yeah,
Yes,
sure.
yes,
I will really share with your opinion, but the only restriction is some people, especially keep smoking. So especially for those, I avoid from surgery. Then I would start, of course, with anti-TNF because it is compulsory in our country as a first line. But this is, I agree with all of you. So such a big delta is very important. Such a early starting, so you can see the results within a week. Then you can decide, okay, it's not working. Even I'm not exaggerating, actually, as I share with your opinion, that this is important here. If it is a first line, why not to start and see what will happen? Then even you can skip the anti-TNF step. I agree.
Okay. Thank you. So we are in agreement. So let's continue, but because there is no, this is not the end, unfortunately. You can imagine. Well, 3 months later, he presents with arthralgias of peripheral joints. Again, CRP is elevated once again, and now, of course, I ask him that he has to see a rheumatologist who says yes. He says that there is now extraintestinal manifestation of Crohn's disease with arthralgia. Although he's okay from the bowel, he doesn't have any pain from the bowel. He's doing okay. CRP now elevated, so we have extraintestinal manifestation from the joints, and this is the problem now because theoretically upadacitinib could be a choice. Now I have you here. You know this algorithm anyway. So you can see that JAK is on yellow. It's a maybe, so you can use it in non-axial spondyloarthropathy. It's yellow. It's not the drug of choice, but it was okay. I mean, he could do it. However, although he was taking that, he developed joint problem. So the rheumatologist said that we had to change the drug because it was not working for him. So now the only option, of course, we have is what you would have done from the beginning. We had to give him anti-TNF. So you see, although we tried, so the Turkish law is right. I mean, you should have started him on anti-TNF from the beginning.
Thank you.
So we started him on infliximab 5 milligrams on kilogram induction week on week 0 and 2, and then he was switched to infliximab subcutaneously 120 milligrams every 2 weeks. I don't remember, Phyllis, we have told last year when we met if you are using the subcutaneous infliximab or not.
No, not yet.
Okay, but it's a very nice option for us because we don't have the patient has not that we don't have to keep the patient coming to the infusion unit every 8 weeks for his infusions. So it gives the patient an autonomy. He can use it himself. Improvement in joint pains, and he has no problems with the bowel. So right now we are in this point that he is taking infliximab subcutaneously every 2 weeks, and he is doing okay in both from both diseases, from the bowel and from his joints. He has to take the drug with him every 2 weeks. That's not so easy for him as he was with upadacitinib, but he is doing good. He's doing perfect, and that's what it's mostly matters to him. So yes, infliximab is a good choice. Has always been a good choice. We have been using it for many, many years, and I think we will continue to use it. I'm telling you once again that the subcutaneous formulation has given us freedom in liberating patients from having to come to the hospital for the IV infusions, and they have been it has been working perfectly well. It's as good as the IV formulation, so there is no problem whatsoever with the subcutaneous injections. So this is our first case. If you want to if we want to say anything more, we'll continue with the drugs in ulcerative colitis in a moment.
And why don't you, I'm sorry, Professor Aykut, why don't you add azathioprine with infliximab? I know you started with upadacitinib and then infliximab, but generally in our practice, we prefer the combination therapy with infliximab.
It's a good question.
Immunogenicity.
Yes, it's a good question. And usually when we start on a second treatment, maybe it's good to do it because we avoid the
loss of response.
Yes. And the formulation of antibodies. He is a male. Okay, he's not so young. I am afraid a little bit with a combination for the lymphoma and all the although he's not so very young, but he's a male patient. He was 41. And the other thing is, again, on my mind, because he was traveling a lot and he was going to places like Morocco, I told you, Algeria, or places that he was in fear of infections. I didn't want to give him double immunosuppression. So although I agree with you, sometimes in real life, I don't do it.
Yes, you're right. And did you check the colonoscopy? I wonder the ileocecal valve stenosis.
I'm sure. No, we haven't done a colonoscopy yet. We're going to program it in the next couple of months. I don't think that the ileocecal valve will be open. But I'm pretty sure that the wall thickening, if we do an MR angiography, it will be better. Yeah. I don't know. Maybe
also intestinal ultrasound. Maybe you can check with
intestinal ultrasound is a very good idea. Yeah. We don't have it in our hospital yet, but yes, it's a very good idea. Yes. True.
Okay.
May I make two comments and share two thoughts with you regarding this case?
Yes, of course.
Now, regarding azathioprine, since this patient we intended to offer subcutaneous infliximab, you do not really need azathioprine. That's another reason why we don't use it anymore in combination. And the other thing I wanted to ask all of you, Nikos and you, since you've been using JAK inhibitors, do you think that, first of all, they can lose response, the patients can lose response? I'm just thinking whether this arthropathy was there at the beginning and was treated with upadacitinib and the patient lost response. That's one thought. And the second thought is whether this arthropathy was sort of paradoxical due to treatment with upadacitinib. We don't really know whether these, despite the fact that they are not immunogenic, these small molecules, whether these are the cases with JAK inhibitors as well. And we know, and we've seen it, that there are psoriasis events with upadacitinib that they may be considered paradoxical. So I'm just asking everyone whether this could have been paradoxical reaction to the small molecule.
Of course, I cannot answer that. The rheumatologist said that that it was extraintestinal manifestation. That's what he said, and he was one who suggested that we should change drug. As regards the persistence on therapy, I believe that patients that go well on drugs, that they are kept on drugs longer than patients with infliximab. I think that patients on infliximab lose response over time more often than patients taking drugs. I don't know if you agree on that.
Yes, but
Maybe you can write, because during infliximab therapy also sometimes, we can see some lupus-like symptoms and arthralgia like this. And sometimes we can miss or underdiagnose this kinds of arthralgia. But it's not easy to show this, I think, for this patient.
Okay, so we can continue if there is no other.
Actually, I agree
Professor
all what you
Aykut,
are saying, but I may add that we had a chance for the early access for sub-Q infliximab around 100 and 150 altogether with the AGAIN group. So more than nearly a couple of years now. So, but we observed that the antibody production is also a case in the sub-Q, because since we have a limited access as an early access, it was only restricted within 150 case. We are following them very closely. Therefore, I can tell you that then the same antibody formation is happening also in the sub-Q form. So even the allergy things. Therefore, the sub-Q may have some advantage, but on the other hand, have some disadvantage. As I can say that when we compare intravenous with the sub-Q medicine, then they both have the balance with advantage and disadvantage.
I agree that the formulation of antibodies is the same in IV and subcutaneous because it's the same drug, it's infliximab, it's the same substance. What they say, studies are showing, and I think I would agree, is that the subcutaneous infliximab keeps the levels of the infliximab trough levels high, more stable, because it's every 2 weeks. And
this
so,
is what we observed.
Yeah, so it's more stable, and that's there's a difference in the stability of the trough levels, not in the formation of antibodies. I would agree with you that the formation of antibodies is the same whether you use IV or subcutaneous. The only thing is that it's more stable and it keeps the levels or trough levels higher and more stable during the period of time.
Okay. We can go.
So we can continue. Yeah.
Okay. So we're moving on with upadacitinib in ulcerative colitis and the key registration study. Sorry. Right. Now, 2 phase 3 studies, again, similarly designed and based on this responder re-randomization pattern. Now, this time for ulcerative colitis, the same dose, 45 milligrams, was offered for an induction period of 8 weeks as compared to 12 weeks. That was the induction for Crohn's disease. And the responders could enter the maintenance phase, and there they could receive either placebo or 15 milligrams or 30 milligrams of upadacitinib. And you can see here that the results were great in terms of the primary endpoint, which was clinical remission at week 8 and at week 52. This was a great result, and the endpoint was met in the case of this study. Now, what about endoscopy? What about endoscopic response? The endoscopic response was very strictly defined in this clinical program. They talked about mucosal healing when endoscopic score was, Mayo score was less than 1. And they're talking about endoscopic remission was when endoscopic Mayo score was 0. And you can see here great results. 63% of the patients on the high dose of upadacitinib during maintenance had endoscopic remission in terms of Mayo score less than 1. And 1/3 of these patients managed to have in endoscopy Mayo score of 0 at week 52. So it works really well, both clinically and endoscopically. Now, the other thing that has already been mentioned is that these medications have a fast, rapid onset of action. And in this clinical program, it was seen that even from day 1, there was significant improvement in stool frequency, rectal bleeding, and bowel urgency for these patients. And again, the results in terms of naive patients as compared to the patients who have failed other biologics were also very good, were comparably good, I would say. And you can see deltas, very high deltas of 47 in the population that has been exposed and failed other treatments. More specifically, we're talking about anti-TNFs and vedolizumab. These were the other treatments in this clinical program. And you can see that 50% of these patients and more than 50% on the high dose did well despite having failed other treatments. What about real-world evidence? Now, this is a cohort from Europe. It included 111 patients, as you can see, and what they looked at is symptoms, which are very crucial for patients with ulcerative colitis. And you can see that the response was very fast. Even at week 8, we had the response clearly close to 80. And then at week 52, 2/3 of patients had symptomatic remission with upadacitinib. Very, very good results. Now, Profundus is a multi-center, multi-country observational study that has not been finalized yet. And I believe Nikos Evangelismos and ourselves have participated and included patients in this observational study. Now, the ultimate goal is for 500 patients to be recruited. Now, this is an interim analysis. 50% of this population was patients that were exposed and failed other treatments. Now, the results were seen within 4 days, the good results. And you can see that 80% of these patients, of this population, in this interim analysis, showed response to upadacitinib. Now, we're talking about very, very good, impressive, I would say, results. And finally, this review with more than 1,300 UC patients showed similar results. Now, have a look at the 94% of these patients were biologically exposed, and interestingly, 53% of those have taken and failed another JAK inhibitor, which is also a very, very important point. Have a look at the percentage at week 8 induction. During the induction, at the end of induction period, the 2/3 of these patients were in remission, in clinical remission. What you see in this light yellow color is the percentage of response according to the clinical program. So what has been shown in this review is that the results in everyday clinical practice are much better than the results that have been reported in the clinical programs. And that's something we occasionally see with these new medications. We see better results in everyday clinical practice. Now, let me show our series of 80 patients, both with ulcerative colitis and Crohn's disease. This work has recently been submitted for publication by Professor Bamnias. And almost all of these patients were biologically exposed. And you can see that remission and response were achieved at very high levels. One more thing, safety was not a problem, but let me say that a lot of patients, a percentage of 12.5, presented with acne, which is something we often see in clinical practice. That's a much higher percentage than the one reported in the clinical programs. That was about 5%. And that reversely, as compared to effectiveness, is a side effect that we see more often in clinical practice with upadacitinib and not so much with tofacitinib. Now, other than that, there hasn't been any serious adverse event in this series of 80 patients, and these are the results during the induction period. How about the scenario of acute severe ulcerative colitis? This is a very difficult condition for which this class of medication may be very attractive because apart from the fact that they are very effective, they act really fast. So these two studies, you're probably familiar with those, showed that tofacitinib in TACO study at the very high dose of 30 milligrams in combination with steroids, with IV steroids, resulted in a very good response. And in the TRIUMPH study, which was conducted in Canada, a lower dose of tofacitinib, but still high, 20 milligrams, was given to patients who were refractory to steroids. And again, 60% of those patients responded on day 7. And it seems that 1/3 of these patients, according to TRIUMPH study, avoided colectomy within a year, up to week 52. Another multi-center study from multiple countries and tertiary centers tried to evaluate whether upadacitinib is comparably effective in this context of the acute severe ulcerative colitis. And it has been shown that the two medications are comparable, and the result, the avoidance of colectomy, that was the endpoint, if you like, was really high. And it was accomplished in 2/3 of the patients who received either medication. Let me just say one last thing, that these JAK inhibitors in this context were offered either before infliximab, in other words, after steroids, if steroids have not been successful in patients, or after infliximab had failed as second-line rescue treatment. But still, this is an off-label thing. It's off-label if we decide to offer it to our patients. Now, we think, and there are data regarding this, that upadacitinib may be the most effective among the three. We don't really have experience with filgotinib, even though I think it is available in Greece, but it's not supported by the industry, so we do not really prescribe it. But this retrospective study, I think it was from Spain, showed, and you can see the blue bars, these show the effectiveness of upadacitinib may be a little bit more effective and perhaps safer than the other two. But that's food for thought. And before I pass the floor to Nikos again, let me come back to what we've already mentioned, that these are all the indications for other immune-mediated diseases that JAKs and in particular upadacitinib have. So we're talking about medications with a very broad range of action. And now Nikos will present the next case.
Okay, thank you, Eva. And once again,
may I interrupt before, Nico?
Yeah. If we have something on the chat.
Actually, this is important. If we are talking about the severely active ulcerative colitis, and if upadacitinib or JAKs rescue the patients from that surgical option, this is something. So we had a multi-center study. It is in the reviewer, about to publish within 3 months, I guess. But our patients was, in fact, they were resistant both steroid and also the infliximab intravenous. So our success within a week was 30%, just week, as a clinical remission. And within 48 weeks, we rescued at least 42% patients who have been both resistant to steroid and infliximab. So this is also important for us, and also matching with Canadian study results. So this is what I would like to add on that. Another issue is the side effect. Eva and Nikos, did you ever met any patients under JAKs, either tofacitinib or the upadacitinib, suffering from isolated, very early developing anemia?
Well, all the drugs can do that, but I don't think that it's one of the most.
What do you mean early on? Yes, we've seen anemia. Yes,
But
within a month or a couple of
Within a
months period.
yes.
So what our rheumatologists warned us about the tofacitinib, that they are come across with some sort of very the rapidly developing deep anemia. Whenever they stop giving, it recovers. In a couple of our cases under upadacitinib, we had that actually. So when we stopped giving upadacitinib, anemia improved. So in another one, we dropped the dose to 15 milligram per day. Then there was no more anemia at all, without any suppression in the white blood count and the platelets. This anemia is isolated one.
Yes.
Okay.
We agree. We've seen that. Yes, we've seen that, and especially
not very common, I would say.
when the
Yeah, it's
patients
not
are
common,
sicker.
but it comes from tofacitinib data as well. We have seen that our rheumatologists have a deep experience on tofacitinib and also the UPA very rapidly increasing the data. So they also have seen that.
Yes.
And
Eva will comment after me on the safety data, and I think, generally speaking, that this is that they are very potent drugs, very well drugs, very good drugs. They're giving solutions, but they have complicated. They have side effects. I think that's the problem, and that's why they have not substituted, let's say, all the other drugs. Because if you have a drug that is very good, it's potent, it's efficient. And it's a pill, then you would expect that everybody would be taking this drug. But why this is not happening? Because they have side effects.
okay, we can discuss safety after this case, I think.
Okay, the case is actually, we have already talked a little bit about this. It's actually a patient with ulcerative colitis, 21 years old, 10 to 12 watery stools per day and blood. So it's like an acute severe ulcerative colitis, abdominal pain, no extraintestinal manifestations. We can see temperature is normal, not acute abdomen. It's okay. White blood cells are elevated. Again, platelets are slightly elevated, ECR elevated, and CRP, as you can see, too, with normal upper limit of 0.5. So he has a colonoscopy which shows pancolitis. The first it was done in a private setting in a gastroenterologist not in our hospital. Sometimes in these cases, IBD, the biopsy says IBD cannot be excluded. It can be an infectious colitis or ulcerative colitis. The biopsy could not differentiate between the two. Stool cultures were negative, though. C. diff was negative. And the doctor outside the hospital in his private practice, he started him on methylprednisolone peros tablets, cortisone tablets, 16 milligrams twice a day. Partial improvement, but the patient was deteriorated after dose tapering, and that's why he was referred to our center. So we have most probably an ulcerative colitis who doesn't respond to prednisolone peros, or at least deteriorates after tapering. But the biopsy is not 100% conclusive. Past medical history, nothing worth mentioning. Appendicectomy, mother with Hashimoto, non-smokers, or nothing worth mentioning here. Of course, as you can understand, we do another colonoscopy. It's Mayo 3. Biopsy in our hospital does confirm UC. It's a matter of time trying to help to persuade our histopathologist to run quickly the biopsy, the specimen, and have the diagnosis. It's not always easy. Immunohistochemistry negative for CMV, C. diff 3 times negative, stool culture negative. So it's a Mayo 3 ulcerative colitis with no any infectious disease or anything else. So we give him, this is a view of our hospital. Feliz, you have been there, you have been here.
I remember the picture.
You remember the entrance? Yes, thank you. So we started him on IV cortisone, 20 milligrams 3 times a day, prophylactic administration of heparin. I'm sure you do that as well. We have to do that. calcium peros, and he was started on parenteral nutrition because it has been going on for quite a while, and he has lost some weight, and his albumin was low. On the 5th day of the cortisone, he was not doing well. 9-10 bowels movements per day, abdominal pain, CRP continues to be high. So we started him on infliximab. We gave him double the dose, 10 milligrams per kilogram. I don't know, that's a kind of another question. If you start with high doses or if we would start with 5 milligrams here. I don't know, maybe I would like to ask you about this. We try to hit hard. Sometimes we know that in ulcerative colitis you have to hit hard, and the drug is going down with the diarrhea. And there have studies showing that it's better to start with high dose. So he was a young patient. He has been not well for many, many days. We thought that we should start with 10 milligrams per kilogram. Then 7 days later, slightly improvement, only 1 or 2, still 8-9 bowel movements per day, abdominal pain again, CRP high. We give him again, I don't know again if you agree with me, we give him again 7 days later 10 milligrams per kilogram. So we hit even harder.
Yes.
And of course,
it's a risk, I think, because if albumin levels still low, and if there is an anemia and CRP is high, generally we discuss with the patient's surgery and rescue therapy, maybe with upadacitinib, but yes, we have to discuss with the patient, I think.
Yeah, so you see, I also have the surgeon here on the picture because we, of course, we asked him to come and give him his consultation. I remind you that the patient is 21 years old. He doesn't want to go to surgery. Of course, it's logical. It's a newly diagnosed patient. You know, if they have the disease for quite a while, they have failed several biologics. They are okay with the idea of going to surgery. They have heard it before. They know that someday it might happen. But telling to a 21-year-old who didn't have any disease before that you're going to surgery and you're going to lose your bowel, you know that he didn't want to listen to it at all. The same goes for his parents. They didn't want to hear anything about that. You know, doctor, please do something. Please do something. I don't know. We're doing. I don't know what else could I do at that point. Anyway, the thing is that fortunately, 7 days later, after the second dose of 10 milligrams of infliximab, that there is slightly, for the first time, we see some improvement, 6-7 bowel movements per day, and the CRP for the first time is reduced. Of course, he's not doing still well. Of course, I'm still telling him that we have to operate him. I don't know if there's any point of continue with infliximab. I mean, we have given him the maximum dose, even more than maximum, I don't know, 0 and 7 days. The patient still refuses to, he doesn't want to go to surgery. So we decide, as you understand, we decide to give him tofacitinib. The thing is that he has slightly improvement at this point. So I think that we have at least the window of opportunity to try this drug. And that's what we do. We give him tofacitinib 10 milligrams twice a day per host. 5 days later, significant improvements. 10 days later, normalization of CRP. 15 days later, 2 or 3 bowel movements. And now the patient is on tofacitinib 5 milligrams twice a day per host. And he has avoided surgery. So I don't know. It's something that we have already discussed. The thing is that we had to make a difficult decision when he was not responding to infliximab. But the fact that he was a little bit better at that point, the CRP was for the first time normal, and the thing that he had a little bit less, he had like 6 bowel movements per day, not 10 or 12. We took the decision to go on with the tofacitinib because, you know, sometimes it's also dangerous to keep on giving medication and medical therapy in a patient that needs to be operated. Because that might lead to, as you know, to complications, and maybe instead of doing good, you might end up harming your patient. Fortunately, this patient did well, So it's a real world data that indeed tofacitinib or upadacitinib can help us in acute severe ulcerative colitis when infliximab fails. And fortunately, the end was good for him. I don't know if you want to.
Yeah, we
else.
have a lot similar profile stories actually.
Yeah.
But Nikos, I agree with you that what we do with infliximab in the active ulcerative colitis, we have to do, in fact, according to reimbursement rules, you have to give first 3 doses as a 5 milligram per kilogram. But nevertheless, we have opportunity to obtain the higher doses because of our unit have some special unit. They share some dosage. Therefore, we apply, first of all, if 5 milligram per kilogram, within a couple of weeks or week, as you did, we apply 10 milligram per kilogram. Again, as a third dose, within another couple of weeks, 10 milligram per kilogram, sometimes 15 milligram. By the way, we measure the trough level.
Yeah.
So we try to behave accordingly. Otherwise, as you said, the young patients, we are not sure about what's going to happen under JAK inhibitors. They will work or will not work. We don't want to lose our chance, first of all, with infliximab. Otherwise, nobody would go back to try again with the high dose.
Yes.
So I agree with you that according to the symptoms, we either apply high dose within a week or within a couple of weeks. And then after a couple of weeks later, another one to be sure that it is working or not working. I agree.
Okay, yeah.
And
So the highest I have given is like this. I mean, like I've given 10 milligrams, 0, 1, and 4 weeks. That's the maximum I have tried. I don't know.
For tofacitinib, we have experience, 4 patients experience. Also, we published acute severe ulcerative colitis. 50% of patients went to surgery, and one of them loss of response, and then we tried upadacitinib. Now it's okay with upadacitinib. So we can see also loss of response with tofacitinib after or during the follow-up, long-term follow-up period.
Again, like in the other patient, again, it's impressive. It's really impressive how rapidly if a patient responds, it's amazing that he does it very fast. This is really amazing. So as I said before, they are potent drugs, they're very good drugs, but now we have to talk about safety.
Shall we move on?
Yes, sure.
Okay. Now let's talk about safety. Now, these are all the areas of concern with these drugs, and infections are not even included. Since you've been using these medications, you already know that an infection of special interest is herpes zoster, which we try to avoid by vaccinating our patients now that the recombinant jab is available in Greece. But let me just discuss these other safety issues. Yes, upadacitinib and all JAKs do affect lipids, and occasionally our patients need treatment for that. They do cause abnormal liver biochemistry, and occasionally we need to de-escalate the dose in order to reduce the levels of liver enzymes. We do see cytopenias, and as Professor Selik mentioned, we've seen anemias not so often, but we've seen refractory anemia, and de-escalation of the dose sometimes helps. But we have also discontinued the medication in one patient due to anemia because we could not deal with this problem. Now, in regards to renal injury, we haven't seen it, but bear in mind that once a patient has a renal problem or a hepatic problem, then the medication, JAK inhibitors, the dose should be modified. But I wouldn't think that sick patients like that, for them, it wouldn't be such a good option, I would say, but this is open for discussion. Let me now comment on thromboembolic events and cancer by moving to the next slide, where you can see that this FDA black box warning is still on regarding cardiovascular complications, thromboembolic events, and cancer for JAK inhibitors in general. And let me just go back a few years and remind to everybody that all this was issued after the results of that trial that was conducted with rheumatoid arthritis patients, the oral surveillance trial. That was a trial back in 2018, something like that, if I remember correctly, that tried to see whether try to compare anti-TNFs with tofacitinib with respect to the risk of these complications. These were rheumatoid arthritis patients more than 50 years old with more than one risk factors for these complications. And it was shown that indeed tofacitinib was associated with an increased risk of these complications. And that's how this black box warning was issued by FDA. Now, that's a little bit unfair, perhaps, because we're talking about a different population. IBD population is not usually that old, and perhaps it's a little bit unfair regarding the second generation, the more selective acting JAK inhibitors. In any case, this black box is still on, and it was based on this black box. These recommendations of the EMA were based on that black box. So Europe recommends that we prescribe these medications with caution when the patients are older, more than 65, when they are smokers, when they have diabetes or any risk factors that increase the risk, predispose her or him to develop complications like cardiovascular complications, thromboembolic events, or even cancer. So caution is necessary. On the other hand, this analysis of more than 8,600 patients who were included in these clinical programs for all indications of upadacitinib revealed very reassuring results, I would say. Now, it seems that if these complications develop, it is in patients, it is about patients who do have one or more risk factors. And probably, I dare say that it is perhaps patients we wouldn't prescribe these medications for. Now, let me gradually, slowly conclude with the positioning of these medications. What do the IBD societies say about them? Now, ECCO does not really take position regarding when to use them. It just states that as you can see at the bottom of this table, that upadacitinib is a very good drug for inducing and maintaining of remission, and it is indicated for axial spondyloarthropathy. And as Nikos said, it may be useful in perianal disease and in peripheral arthropathy, and perhaps it may be considered in older patients. The same stands for tofacitinib in ulcerative colitis. It is as good as anti-TNFs and non-anti-TNF biologics for moderate to severe ulcerative colitis. It does not give us any guidance. On the contrary, AGA clearly states that for naive patients with ulcerative colitis, moderate to severe ulcerative colitis, upadacitinib is a medication that is considered a medication of higher efficacy, whereas interestingly, the other two are considered medications of intermediate efficacy for naive patients with ulcerative colitis. And for exposed patients, it's clear that the two out of the three available JAK inhibitors are medications of higher efficacy. Filgotinib comes second, let's say, with an intermediate efficacy. And let me conclude by highlighting the advantages of this class of medications. As we already said, many times during this presentation. They are very powerful medications. They're very powerful both for naive patients and for the patients who are more difficult to treat. They have this very fast, rapid onset of action, which makes them really attractive and perhaps render them candidates for replacing steroids, either in the inpatient setting or in the outpatient setting. They have this very broad range of indications. Obviously, it's an oral treatment that's very attractive to patients, and it may become an option in acute severe ulcerative colitis. There hasn't been another option for so many years now since infliximab, and also for perianal disease. From the downside, safety is an issue. It's still an issue, even though experience is growing. And of course, pregnancy is also a limitation. We don't prescribe these medications in young women of reproductive age unless pregnancy is planned later on. So unless control of inflammation is absolutely necessary before planning reproduction. This is what I wanted to say, and thank you very much for listening.
Thank you, Eva. I want to ask something about JAK in real clinical practice using. We didn't discuss about vaccination, but I'm sure you use vaccination for viral infection. And how about your experience about infections, pneumonia, urinary infection? Because when the infection is occurred, sometimes we have to stop or interrupt the drug. And after after finished infection, do you use reinduction, or do you need reinduction, or do you use normal regular dose, maintenance dose? What's your practice?
Okay, let me say that yes, we do commonly see infections of usually of mild to moderate severity. Secondly, we always interrupt treatment, and no, we do not usually go back to induction doses. We go back to the dose the patient was on, unless we're talking about very long time of discontinuation.
Usually it's just a week.
Exactly, which is something that hasn't happened so far. We haven't stopped the medication for more than a month, let's say. So
the good thing about these drugs is that they have a short half-life. So when we stop them, they are eliminated from the system quite soon. So that is very helpful. And since they have a rapid onset of action, again, if you start them, they act again quite often. So it's not a problem. You can stop them for 7 or 10 days without reinduction, I think, and you can continue the medication once the infection is there. The thing is about these drugs that when they were first, when they came to the market first, they were talking to us about about the hyperlipid, about the lipids, about the herpes zoster, and this is something that we don't see so often. And then we started seeing acne, we saw other complications.
How about acne? Because sometimes we have to stop the medication.
It is kind of common. It's more common than we thought. I mean, it's true.
Yes, but it usually does not result in discontinuation. Yes. Usually topical treatment helps, but you're right. Occasionally, especially
sometimes white
yes.
whole body acne form, pustuliform disease, we have to stop it.
It's true.
And how about perforation? We have in our case series in Crohn's disease, perforation we have.
We had one case in Greece. We had one case in a patient who was really sick. I have to say. So we're not exactly and he was operated on. So we're not sure whether this was because of inflammation or because the effect of the medication.
And on the other hand, I want to say that because we are afraid of the side effects, we don't prescribe these drugs in patients who are over 65, if they have a history of heart failure or whatever. So we're very careful about these drugs. So maybe that's why we don't see these very difficult side effects, let's say.
Yes, but we do see infections. We
do see infections.
Yes,
and we do see acne, and we do see anemia could also be a problem. Herpes zoster not so much, but then again we vaccinate our patients, so we haven't seen that. I don't remember seeing even once. Even one.
No, I haven't seen either.
No.
On the contrary,
after vaccination, we didn't see anymore.
Yeah.
yes.
And one more question from the audience. And Professor Hale Akpınar, thank you, Professor Akpınar. Why did you prefer parenteral nutrition for ulcerative colitis patients, I think? And some patients complain that UPA pills are excreted in the stool without being absorbed. What's your opinion?
I haven't really seen that. I don't know. I've heard it from other in conference. I have heard it from other professionals, medical. In my case, I have not seen it. None of my patients have said that to me. I've heard that. I have heard it though from other patients, from other doctors. Yes, but I haven't seen it personally. I haven't seen it. I don't know why it's happening. Sometimes in ulcerative colitis, that's what I told you. We know that the drugs, even in infliximab, as I said, that there's so much. The bowel movement is so rapid that they lose the drug with the stools. Now, about the parenteral nutrition, usually when we have an acute severe ulcerative colitis and the patient is not responding to corticosteroids, the surgical option is always there, and the surgeons want us to take care of the patient, and they want to operate on a patient with good nutritional status, because if they operate and the patient has low albumin or whatever, then the complication rate is higher. So they want us to send the patients to the surgeon with a good nutritional status, and that's why we do that. Yeah.
And second question from audience: what's the discontinuation time of the UPA if the zona zoster occurred?
I think the dermatologists suggest once the skin lesions have subsided, at least 15 days later, 15 days after these lesions have subsided, you can restart the medication. We always consult dermatologists regarding this, but yes, it's sometime after the regression of the skin lesions.
And do you think that the location of lesions is important? I mean, if it's cranial side, maybe we have to interrupt at least 2 weeks or 3 weeks, but the other side, maybe we can use after 1 week.
I absolutely agree. It does depend on the site of the infection, but we haven't so far seen atypical sites, let's say, or severe herpes zoster, to be honest.
Okay. And another question. Thank you for your excellent presentation. How you tried combination therapies with UPA? Which ones? Combination therapy. And I want to add one more question. We know we use UPA monotherapy as a monotherapy, and some drugs contraindicated with combination. But do you use mesalamine combination as for ulcerative colitis, especially?
Okay, combination therapy with UPA or JAKs. We don't usually, there is no point of using azathioprine or methotrexate, since there is no immunogenicity in this drug. So I don't think that it's necessary or that it has any efficacy in adding immunosuppressions, classical immunosuppressions in JAK when you prescribe JAK inhibitors. Now, there have been studies and we have done we have prescribed UPA with vedolizumab, but on a setting of a clinical trial. It's not allowed. We cannot do it on an everyday clinical basis. Only on clinical trials we have. Maybe you have also participated in some clinical trials that they are prescribing vedolizumab and upadacitinib as induction, and then continuing with vedolizumab as maintenance therapy. It seems that you have to be working, but I have my only experiences in the context of clinical trials. I haven't done it in everyday clinical practice. What was the other question? Yeah.
Was there another question, Phyllis?
For mesalamine combination with mesalamine in ulcerative colitis, do you use mesalamine or you stopped everything?
I do not usually discontinue mesalazine unless deep remission has been confirmed, and this is something I'm used to do. We do in our department with other biologics as well. We do not discontinue mesalazine, and I know there are conflicts regarding this issue. Whether I'm not sure whether mesalazine is actually necessary, but we do not discontinue it unless we have confirmed deep remission for a long time, and then perhaps we will withdraw it. I don't know about.
No, I agree with Eva. I'm not a fan of stopping mesalazine, generally speaking. But definitely I would not stop it when I start by a biologic. Some doctors, some colleagues, when they start a biologic, and also many patients, they ask, they want to stop. They say, if I start a new therapy, why should I continue with the other one, which has, in quotation marks, has failed? But I would never stop mesalazine when I start the biologic. I would definitely consider it after, I don't know, 6 months, 1 year, maybe even longer, as Eva says, when we have deep remission. But generally speaking, I prefer to continue it and keep it.
I agree with you. And Professor Aykut Ferhat Çelik, do you want to add something?
Thank you very much for all your comments. We are all agree, actually. The clinician, being clinician is something important. We do observe and behave in the same way, actually. I agree with all of you are saying. The only issue, we do use the JAK inhibitors in a much higher dose than the rheumatologist. Therefore, we have to pay extra attention. I believe it, that because we have seen the number of cases with the urinary infection, especially in elderly people, some scalp area fungal infections, and then eruptions, the acne formations, some viral infections, all we could manage to control. Okay, we can manage them to control, but those are the realities. Another issue I would like to highlight, maybe we can use this in the clinic. So if you may have a clinical remission very rapidly, but whenever if the patients miss any couple of doses, it starts again, the clinic to get activated till the endoscopic remissions is the case. If there is endoscopic remission, even if patients miss their dosage, clinic doesn't necessarily get activated. But it is a quite nice indicator that your patients may respond and you can have a clinical remission. But if they miss one of their dosage or a couple of their dosage, their symptoms start immediately because very short half-life of this drug is some have advantage and disadvantage till the endoscopic remission. This is another issue. Thank you very much for all your saying, all your comments, and it is also interesting.
We want to continue these meetings with you. It was really fruitful, and we would like to.
Yes. It was perfect. Thank you very much. We discussed a lot, and we talked all things about JAKs, I think.
Yeah.
At the beginning, Eva said we will discuss little, but we talked about more than little. Thank you
very much.
Thank you.
This was great.
We will be looking forward to welcoming you in Greece.
Yeah, we are waiting for you.
Yes. It's an honor to see you
waiting for you
here. So
Thank
thank you very
you.
much.
Good night. Thank you very
I
much.
think we
Good night.
can
Thank
stop
you very
here.
much.
Good night.
Also,
Thank you.
thanks for our audience.
Of
Thank
course. Thank you all.
for all colleagues. Thank you for
Thank you.
participants.
Bye-bye.
Bye.